All right, so I'm going to do a little quick recap on blood pressure, hypertension, tips on taking blood pressure. You want to ensure that the cup is on correctly and that the correct size is available. You don't want to place it closed, you don't want to put it upside down or inside out. If there's the artery line, you want to make sure that it's at the artery. If you are in an outpatient setting, you want to have the patient seated because you want to support their back and their feet. If you are in an inpatient setting, lying in the bed is fine because their feet are rested and elevated. It's not a big deal, but if they're sitting, they need the feet to be relaxed, so no standing. If they are seated, you want to ensure that the arm is at the level of the heart. You don't want them to have any conversations. You want to ensure that they don't need to urinate, and you want to have them keep their legs uncrossed because having their legs crossed will raise their blood pressure. Most importantly, if you're taking somebody's blood pressure and it's more than 160 over 100, you should retake it and ensure it's a true reading. If it is that high, you want to do a neuro assessment. So you're going to look in their pupils. You're going to check their grips, see if they have a dripped, symmetrical smile, if they are weak on one side or the other. And if their blood pressure is low, if the systolic is 90 or less, you want to do an assessment of cardiac, so dizziness, lightheadedness, they feel like they're going to pass out, if their heart is fluttering. These are the AHA guidelines for blood pressure because they just released them in 2017, and so they've changed a little bit. There's still J&Z 7 guidelines that say 140 or over 90 is hypertensive. I'm not going to trick you and give you a number that could be hypertensive or might not be hypertensive by one, but will be by another. It's going to be obviously hypertensive. So your end result of not controlling blood pressure, you can have stroke, heart failure, sexual dysfunction, vision loss, heart attack, kidney disease, kidney failure. Blood pressure, the patho, is cardiac output times stroke volume. So this means like an increased cardiac output, increased peripheral resistance in the veins and arteries is going to increase blood pressure. You have different regulators in the body. You have arterial baroreceptors, which are located in the heart, and they will help regulate your heart rate up or down, however your body needs to compensate. They also cause vasoconstriction and vasodilation. The body also compensates with fluid volume regulation, so if you're hypotensive, then your body is going to tell your kidneys to hold on to some fluid. And if you're hypertensive, your body's going to tell your kidneys to let go of some fluid. The renin-angiotensin-aldosterone system, I've talked to this thing to death. And then the vascular autoregulation system, which maintains consistent levels of tissue perfusion. That's how your body compensates in a normal person, okay? A person that is functioning like they should be. You have different types of hypertension. You have essential and secondary. Your big 95% of the population is essential or primary. And then secondary is they know where the blood pressure issue is coming from. So it could be medicine, it could be coarctation of the artery, those kinds of things. So the majority of the population has essential hypertension. You can also have white coat or masked hypertension. With white coat, you have a normal reading outside the office, but inside the office it's elevated. And then with masked, it's elevated outside the office, but normal while you're in the office. The risk factors for hypertension. We have sodium and fat, obesity, oral contraceptives, smoking with the oral contraceptives, not smoking alone, because smoking alone does not cause chronic hypertension, stress, alcohol, age, being African American can cause you to have hypertension. D vitamin deficiency, inactivity, and caffeine and cholesterol. With the secondary, you can, it could be aldosterone, bad kidneys, catecholamines, Cushing's, drugs, and endocrine. Please remember that smoking itself does not cause chronic high blood pressure. Smoking is a vasoconstrictor, and it can increase your blood pressure temporarily, but there is no data to show that it chronically elevates your blood pressure. If a hypertensive person smokes, their risk of dying from heart disease significantly increases. So some thoughts about the geriatric population. As we age, hypertension risk increases. One of the reasons it increases is because we have changes, structural and functional changes to our heart and to our arteries, atherosclerosis, and they are not as elastic as they were in our youth. So this increases our peripheral resistance and causes high blood pressure. We also have an increased stiffness in our heart, and the arteries don't buffer like they should. And because of this, they have an inability to store energy that is needed, which creates an increased diastolic pressure, which creates a widened pulse pressure. When you have a pulse pressure that is above 50, it's associated with increased intracranial pressure, atherosclerosis, aortic insufficiency, and fever. If the geriatric population needs medicine, that medicine should be started low and it should go slow, because geriatrics are very vulnerable to orthostatic hypotension. So we want to make sure that we don't lower their blood pressure too much. They are susceptible to volume depletion and sympathetic inhibition, which results from the adrenergic antagonists. So we want to teach safety measures such as position changes slowly and support devices for walking. So the way we need to promote health, we need to decrease weight, have a BMI of less than 30, regulate our blood sugar. We limit our caffeine, limit our alcohol, manage stress. How do we manage stress? Well, there's exercise, there's yoga, there's meditation, stop smoking, work out the heart 3 times a week, that's aerobic. And then we also limit our sodium or fat. So pretty much we're addressing all our risk factors with that health promotion, right? So if we know our risk factors, we know how to promote our health. Remember, blood pressure is called the silent killer. There are pretty much never any signs, symptoms until it's, you have end organ target damage. And so, accurate blood pressure measurement is essential because of the fact that most of the time you don't have symptoms. If a person does have symptoms, they are going to have headache, facial flushing, dizziness, fainting, some visual issues, and they could have some nocturia, which is going to the bathroom at night. The reason you have nocturia is because your blood pressure is elevated, and it causes your kidneys to basically overload because of the elevation. But by the time you have symptoms, you have some kind of damage. Coronary artery disease and MI are your most common, but you could also have kidney damage because of the proteinuria, because it's asymptomatic, as you learned with diabetes. And then the increased workload that you don't even know you're having tends to lead to a hypertrophy of the cardiovascular, so you will eventually be in heart failure. So the target organs, what blood pressure targets? We have the vasculature, so atherosclerosis, aneurysms, aortic dissections. We have our heart. We have kidneys, brain, and visual issues. Those are our target organs. So routine tests that we would expect, a urinalysis. If you have a urinalysis, you would expect to see microalbuminuria or proteinuria, which is just protein in the urine. You could see a metabolic profile, which would have the BUN and creatinine elevated. The glucose could be elevated, but having elevated glucose doesn't mean you have high blood pressure. It just means that you don't control your glucose, which could contribute to complicated blood pressure issues. You could see cholesterol counts, and the cholesterol could be elevated, which again doesn't mean a person's hypertensive, but that can contribute to hypertension, complicated. And then we could see an EKG and an echocardiography if a left ventricular hypertrophy is expected. Echocardiography is an ultrasound of the heart, and the EKG is just the electrical tracing of the heart. And again, an EKG isn't going to say that you're hypertensive, but when read by the cardiologist can tell from the reading that they could be at risk or they could have a history of high blood pressure. So, even if it's not said, please remember that any client that is on antihypertensive therapy should be instructed to change position slowly. Be careful when getting out of bed, driving, climbing stairs until your med effects are fully known. Because this is blood pressure medicine, it's going to affect your blood pressure. So, medication therapy. We have diuretics. The first line for uncomplicated hypertension, thiazide diuretics. The loop and thiazides are going to decrease your blood volume and your renal blood flow and your cardiac output. So your sodium, body's going to get rid of sodium, which is also going to get rid of fluid. But you're also going to have side effects of hypotension, weakness, drowsiness, dry mouth. And when you are administering these, what do you as a nurse want to be concerned about? Well, you want to be concerned about potassium. You also, since you're going to be concerned about potassium, hypokalemia, you want to watch for muscle weakness and irregular heart rate. You're peeing out everything, so you're going to monitor for dehydration. The education that you want to give to a patient, you're taking a diuretic that could cause your potassium to go decrease, so you want to give them education about potassium-rich foods. What are potassium-rich foods? Citrus fruits, fish, mushrooms, avocado, all these things. Another medicine is calcium channel blockers. Calcium channel blockers generally end in pine. They will reduce the cardiac afterload and the workload, and of course your side effects are hypotension, but it can also affect your heart, so bradycardia, dizziness, edema. You want to not discontinue suddenly. The contraindications for calcium channel blockers are sick sinus syndromes and heart blocks. When you are on a calcium channel blocker, you're going to consider, or you're going to have vasodilation. So, again, you want to give them education about possible orthostatic changes. You also want to teach them to take their pulse before administering and to avoid grapefruit juice. Beta blockers, anything that ends in OLOL is a beta blocker. They cause vasodilation by decreasing cardiac output and heart rate, blocking the beta-adrenergic receptors of the sympathetic nervous system. So, again, your side effects, hypotension, bradycardia. You might have fatigue or weakness, especially when you're first starting them. And heart failure. You'll see a lot of patients with heart failure that are actually on a beta blocker. A lot of times they use beta blockers for unstable angina and a history of an MI. And if you have a history of an MI, you have heart failure because part of your heart died. The big thing about beta blockers is they can mask hypoglycemia. So we want to be cautious, especially with our diabetics, because if their hypoglycemia is masked, they might not exhibit symptoms. But people who aren't diabetics can also be hypoglycemic. You want to not abruptly stop this medicine. We have angiotensin converting enzyme inhibitors, which are your prils. They stop the conversion of 1 to 2. By stopping the conversion of 1 to 2, our body never makes 2 and never makes aldosterone, and so our blood pressure never goes up. They help reduce peripheral resistance. The big side effect that you need to know with ACE is angioedema. It's not common, but it is life-threatening because you're having an edematous airway, so you can't breathe. Other things, low blood pressure, tachycardia. ACEs also can hold on to potassium. So if you are giving ACEs and you're giving insulin, then you need to watch for their potassium. Make sure their potassium's okay, because insulin is the key, right? It's going to get the potassium into the cell, and then you have an ACE on top of that, so you could have hyperkalemia. And you want to educate them to report cough and signs and symptoms of hyperkalemia. With your ARBs, angiotensin receptor blockers, again, ends in artin, blocks angiotensin II's effect. So people who end up having an angioedema reaction on an ACE will get put on an ARB. They'll get taken off their ACE and get put on an ARB. And ARBs almost do the same exact thing, except instead of keeping the conversion from happening, they are blocking the effect. They cause a decrease in peripheral resistance, again, hypotension, hyperkalemia, so ARBs can cause elevated potassium too, so you want to teach signs and symptoms of hyperkalemia, contraindicated in pregnancy. And avoid foods that are high in potassium. So I didn't talk much about aldosterone receptor antagonists because it's something that I haven't seen very much. It's called eplerenone is the example. It will block aldosterone, which promotes potassium retention and excretion of sodium in water. The central alpha agonist, the example is clonidine. It inhibits the reuptake of norepinephrine. So a big side effect is that it can make you drowsy because it inhibits this reuptake. By inhibiting this reuptake, it helps decrease peripheral resistance. But if a person is drowsy, if that's their big side effect, you want to give them education to be cautious when operating any type of motor vehicle until they know how they're going to react. And again, considerations, if it causes drowsiness, you would want to maybe not give it in the middle of the day if they're going to be drowsy, if it's their first time taking it. Lots of people have been on it for quite some time and it doesn't bother them. But if it's their first time taking it, that might be a consideration you'd want to think about. The alpha adrenergic antagonists And the example is prazosin, and it vasodilates. So you want to start with a low dose, give it at night because it can make you sleepy. And you want to monitor blood pressure for 2 hours after initiation. So the very first time that they're taking it, their blood pressure needs to be monitored a little bit more closely. So, education, what you want the patient to know. You want to tell them to report any manifestations of electrolyte disturbances, specifically potassium. They're hypo or hyperkalemic. So what are our disturbances? So remember to report manifestations of electrolyte disturbances. So if you need to review what hypokalemia and hyperkalemia are, go review it, please, because they're kind of important to teach. Stress to the patient the importance of complying. Even if they are feeling fine, they still need to take their medicine. If they are at the point that they need medicine, they need to take their medicine. There is no, I'm better and I'm good, I don't need it. You do need it. If they are able to control it with diet and exercise, that's great. But once they get to the point of taking medicine, they need to comply. Give them verbal and written instructions on any new medicine, and then make sure when you're giving them written instructions that they know how to read those instructions. Ensure that they can get their medicine. So if they are not able to afford their medicine, you need to discuss. Well, there's $4 list at Walmart. Is there something we can get them off that? Publix has some free stuff, so you just have to investigate. Regular checkups. If somebody has hypertension, they need to be checked up regularly, once a year. Remember that your older population is more susceptible to orthostatic hypotension and other effects, and they need lifestyle changes. So what lifestyle changes can we do? Well, the DASH diet. What does DASH stand for? Dietary approaches to stop hypertension. The DASH diet is high in fruits and vegetables and whole grains and low in salt. And it has low-fat dairy options. It's great. So if you have a patient that's coming in and they need some education on some diet changes, you can go to a computer and Google DASH diet and get a ton of stuff and talk to them about it. The client education, you want to give them weight reduction and maintenance. Aerobic exercise 3 times a week. They need to start their exercise off slowly if they've never exercised before, and advance is tolerated because some people can't do 30 minutes of aerobics at one time when they first start. You want to encourage cessation of smoking and stress reduction. Know the difference between hypertensive crisis and hypertensive urgency. With urgency, you are not going to have target organ damage. But with emergency, you will have target organ damage. So you could have a headache with urgency, but you're not going to have anything else. And it can occur in an outpatient setting. You want to get the blood pressure down to 160 over 110. I think the bottom number is a little high, but that's what the book says. With emergency, you want to reduce your blood pressure, but you don't want to reduce it too quickly, over 2 to 6 hours. Your only exception with that is if they have an aortic dissection. You want to get the blood pressure low at that point, because if they have an aortic dissection and the blood pressure is too high, it's going to keep dissecting. Hypertensive crisis, your actions, you need to recognize your manifestations. So if they have some kind of target organ damage, if they're having a transient ischemic attack, blurred vision, tingling numbness, weakness, paralysis on one side or the other. Those are some examples. Then, and their blood pressure is ridiculously elevated, it's like 200 over 120, then hey, they're having some hypertensive crisis. IV drips, going to manage it with nitroprusside. Blood pressure is monitored every 5 to 15 minutes until they're stable. These patients are in the ICU, and you're going to constantly be assessing their neuro and their EKG. So that is high blood pressure for you. And now we're going to talk about peripheral arterial disease.